Hello, my name's Aisha Khader, and I'm delighted to be joined today by Professor Joseph Rhodes-Cabu, who is a professor at Laval University and the Quebec Heart and Lung Institute in Canada. And we are going to discuss his paper published in the upcoming issue of JACC Cardiovascular Interventions, titled Impact of Early Hemodynamic Valve Deterioration on Long-Term Outcomes Following Transcatheter Aortic Valve Replacement. Thank you for your time, Professor Rhodes-Cabu.
Thank you. My pleasure to be here.
Yeah, so in terms of discussing your manuscript, could you tell us a bit about the background to this study and also perhaps explain to us the significance of hemodynamic valve deterioration? Why is this an important parameter?
Yes, in fact, the background of the study started many years ago, where we realized that there were some patients that after a few weeks after the TAVI procedure had an increase in the mean gradients. This was a small proportion of patients, but we thought that this could be an important parameter. As you know, after that, there were many studies talking about subclinical valve thrombosis and the potential clinical implications of this phenomenon. And we decided to revisit this parameter or early hemodynamic deterioration that we defined in a very simple manner, meaning that when you have a change which is more than 10 millimeters of mercury in the mean gradient, we consider this as a significant parameter for early hemodynamic deterioration. As you know, in the bar 3 is a more complex definition, but in the real world daily practice, we thought that this single parameter that is very easy, much more than calculating the valve area, etc., could be clinically relevant. Then we have a prospective database with prospective data collection starting at the very beginning of our TAVI experience in 2007. And we evaluated close to 2,000 consecutive patients that we followed. And we had a median follow-up of 3 years for these patients. And we were able to determine the incidence of these early hemodynamic deterioration and then the associated factors and the clinical consequences.
So in terms of methodology, this was based off of a registry. Could you elaborate a little bit more about your methods and as you said again, the main results and the downstream clinical impact of HVD?
Exactly. This is a local registry in our center where we collect the data prospectively, as I said. And then the methodology is that you always have an echo at hospital discharge. And then you have the majority of patients have an echo between month 1 and 3 following the intervention. We look at these two echoes and we realized that a bit more than 3% of the patients had what we consider a significant increase in mean gradient, as I said, more than 10 millimeters of mercury. And the factors associated with this increase were small annuli, valving valve, and the lack of anticoagulation at hospital discharge. This increase in mean gradient, as a mean, the increase was 15 millimeters of mercury, meaning that if you leave the hospital with a gradient of 10, it went up to 25, the mean gradient in a few weeks. And the clinical consequences were that this mid to long-term follow-up was associated with higher rates of bioprosthetic valve failure, higher rates of stage 2 or 3 valve deterioration. And then what was a bit more maybe surprising, I would say, and original, is that this was associated with a threefold increase in the risk of stroke over time, meaning that really this very simple parameter was associated with extremely negative consequences over time, and this is why we thought was important to be reported.
Of course, and all of these results are very nicely depicted in your central illustration. But we know this is an observational registry-based data analysis with its inherent limitations. So what do you see as the next frontier in terms of further research on this topic?
I think that what these results tell us is that probably this is a thrombotic phenomenon, again, subclinical, in relation with these subclinical thrombosis that are diagnosed by CT. And I would say it provides some rationale for trials trying to evaluate anticoagulation after TAVI. Maybe not long term, but at least as we do in many surgical involved interventions, at least for a few months of anticoagulation. The other thing is that this could be maybe more a tailored approach in the future. In fact, in clinical practices nowadays, we pay attention to these changes. And if we see these changes, these mild hemodynamic changes, we perform a CT, but sometimes if the CT cannot be performed, we start anticoagulation right away. Meaning that we switch the single antiplatelet therapy to anticoagulation in these patients. And when our experience is that when you start anticoagulation very rapidly after diagnosis, these phenomena can be reverted in many, many cases. But if you wait, and you see in the paper that anticoagulation was not prescribed routinely, and the results were not very good in terms of reverting this phenomena.
Fantastic. Thank you very much for summarizing the data and also outlining the key concepts as a takeaway for the practicing clinician. This is a really interesting analysis of a seemingly easy to do parameter, which is echo and echo as baseline, then followed by routine follow-up as per the guidelines, and how it can impact clinical outcomes downstream. Thank you very much for your time. This issue of this manuscript, of course, is published in the October 27th issue of JACC Interventions with an accompanying editorial. And we really do appreciate your in-depth analysis with this, Dr. Rhodes-Cabot.
Thank you very much.